Thank you so much for the opportunity to participate in this amazing Congress. It's my great honor to speak to you today about the management of acute heart failure in older patients. I don't have any disclosures, no relationships with industry, that is. I do receive some salary support from the United States National Institutes of Health for my involvement in some research projects. When we're asking as to whether there are any cautions in related to management of acute heart failure in older adults, I would say that the answer is a resounding yes. And that's why this is such a great topic to discuss today. Here are the different domains that I would suggest we need to consider. One is the diagnosis, the medical management is the next, and then goals of care is something we very infrequently think about when we're talking about management. Guidelines are important to check out because we need to make sure that they're actually appropriately applied to older individuals. We also have to talk about the impact of frailty, especially as it regards rehabilitation of patients. I just want to mention from the diagnostic standpoint that there are a number of important overlaps between heart failure syndromes and frailty, which of course is very common in older adults. As you can see here, cognitive impairment, fatigue, cachexia, weakness and muscle wasting, depression, anxiety, poor exercise tolerance, and poor nutritional state are all things that are found both in frailty and in heart failure and can sometimes complicate the diagnosis. Now, moving on to medical management, which is the real part that we need to talk about today, I think, as everyone's aware, the hallmark of treatment is decongestion. When patients present in acute decompensated heart failure, we need to provide them with diuretics so that they can reduce their congestion. At that point, hopefully within the hospitalization, we can begin to either introduce for the first time, if this is an acute first-time presentation, or reintroduce guideline-directed medical therapies. And that continues after the patient is discharged from the hospital as we titrate the doses to target. And hopefully we get to that point at which the patient is then climbing mountains, as we can see in the lower left-hand side of the figure. The problem is that we also have competing or complicating disorders that can create some problems along the way. And so we would like to think of it as being simple. All we need to do is decongest the patient, but the reality is it's not that simple. There are 9 at least common health conditions that older adults have to face, and these can all be complicating factors. We think about forgetfulness and confusion, vision problems, balance and falling, hearing loss. All of these things can definitely complicate our ability to take medicines and tolerate them. And then we add on things like dizziness and sleep-disordered breathing, osteoporosis, urinary incontinence, nutritional problems. All of these create even more difficulties. And even as you see in the lower right-hand corner of the figure here, 2 groups of older adults that require special care, those with multiple diseases, but then also those who have symptoms of uncertain or unknown causes. We end up with a much more complex picture than it would initially seem. To talk about specific impacts, depression, hearing loss, vision problems, and also our problems with cognitive impairment, be it dementia or delirium, can complicate medication adherence and can also lead to both overdosing and underdosing. Urinary incontinence puts one at some risk for urinary tract infections, and of course, this can complicate our application of SGLT2 inhibitors. Imbalance and falls and dizziness can complicate our use of vasodilators and diuretics, as can stiff vessels and wide pulse pressure. We may have to look at mean pressures instead of systolic pressures when we're titrating our medicines. Multimorbidity can create lots of difficulties when we have to think about the kidneys when prescribing and titrating our vasodilators, diuretics, and particularly aldosterone antagonists. Bradycardia obviously can complicate our use of beta blockers. And so this brings us to the concept of what has been called deprescribing. Now, I actually don't like the term deprescribing. It sounds very negative. And it seems to go against all of the things that we're taught that we do, which is mostly prescribing medications in acute decompensated heart failure. But really, if we think about it not as deprescribing, but as rational prescribing and appropriate prescribing, or even tailored prescribing, individual prescribing, I think we really reach much more closely to what we're very used to doing and what makes a lot of sense. In terms of this concept, I had the privilege of being part of a writing group. We produced this top 10 for cardiovascular care of older adults. And one of the things we said is that basically there are exceptions when thinking about using evidence-based medicine in the care of older adults with cardiovascular disease, because less may be actually more, because we avoid a lot of problems. In particular, we have to think about polypharmacy. Polypharmacy is very common in the United States, 1 in 3 older adults, usually described as more than 5 medications that the patient has to take chronically. And when we're thinking about polypharmacy, we have to weigh the benefits versus the risks. Now, clearly, for most of our medicines, there can be improvement in quality of life and reduction in hospitalizations and improving survival. But we have to balance those benefits with the risks of things like out-of-pocket costs and drug-drug interactions and adverse events from the drugs. And of course, low medication adherence, because the more pills you take, the less likely you are to take all of them. There's also this thing called the prescribing cascade, and I'll just illustrate that with one of the very common prescribing cascades that we run into. Say a patient has hypertension, we prescribe amlodipine. That gives the patient lower extremity edema, and then we prescribe a diuretic to get rid of the edema. That causes the potassium to go down, and now we have to give a potassium supplement, and all of a sudden we have 3 medications when we just intended to give 1. Here is a central illustration of an overview article that we wrote a few years back looking at how deprescribing actually should take place. You can see on the left-hand side here, there are triggers to deprescribe or to think about the medication list and maybe either titrate down medicines or get rid of them entirely. Obviously, if there's an adverse drug reaction, or if we count up the number of drugs, and there's a whole lot of them, if we see prescribing cascades that have happened, or if the patient is end of life, and we really don't need these medications to achieve the patient's focus on palliative goals. So after we've looked at that, then we enter into our process circle. The first step is to review and reconcile. We look over the medication lists, and we see if there's anything that we need to eliminate or decrease. The second is to assess the risks of adverse drug events. And this allows us to examine each of those medicines in light of risk as well as benefit. Then we move on to assessing the candidacy of individual medications. Are these medicines doing what they're supposed to be doing, or perhaps they're just there and potentially causing problems? Then we prioritize drug discontinuation. There may be a number of different medicines that need to be stopped or decreased, but we don't necessarily want to do these all at the same time, so we have to prioritize them. Finally, we actually discontinue them, and then very importantly, we need to monitor for adverse events of discontinuing the drugs. The American Geriatric Society has put out this document called the Beers Criteria for Potentially Inappropriate Medication Use in Older Adults, and this gives a number of different medicines that we need to think about decreasing or eliminating because of the risk for adverse events. I won't obviously go into all of these, but you can look it up on your own. So again, it may seem simple to manage these patients and to discontinue medicines that are no longer working, but of course it's not, and we need to actually enter into that process, particularly in which we evaluate the effects of discontinuation. And this brings us to the guidelines. The guidelines, as we know, help us to manage patients, and these are the 2022 guidelines for the management of heart failure, not necessarily acute decompensated heart failure, but importantly, they note some things, that there are additional comorbidities that happen that can very much complicate heart failure management. And of course, older individuals tend to have more of these comorbidities. So they give some very helpful advice in addressing things like anemia and hypertension and sleep disorders and diabetes. And of course, there are many more on top of this. But again, we have to be cognizant of the fact that our prescribing cascade can complicate it. A patient with anemia might be put on oral iron therapy, leading to constipation, and then we have to start the laxatives, and all of a sudden we have a prescribing cascade. Other issues with the guidelines are the fact that guidelines, for the most part, are focused on populations because it's these large data sets of multiple people that show us that patients are more likely than not to benefit from the therapies that we're looking at, or in the case of class 3, they're less likely to benefit. In fact, may be harmful in the majority of patients, or substantial, significantly significant part of them. But this has to be contrasted with the fact that older patients are very much individuals. And the old adage that once you've seen an older individual, you've seen one older individual is very true. Patients can be very debilitated, or they can be extremely capable and doing very well. And we have to individualize things, including the applications of guidelines. And we have to ask ourselves, when is it appropriate or inappropriate to extrapolate these guidelines to older individuals? Because, as you know, many of the guidelines are based on data that did not include older individuals in the studies. And so they don't necessarily fit the profile that is being addressed in the guideline. We have to think about the different characteristics even of the disease processes. I think a classic one, when we think about the etiology of heart failure, older individuals may be more likely to have amyloid as an underlying etiology rather than, say, dilated cardiomyopathy. And of course, they still have a lot of ischemic cardiomyopathy, but we have to think about some of these other etiologies. The anatomy and pathophysiology of the disease process may be quite different. And of course, patients who are older tend to present differently. And they have a different trajectory and a different prognosis. And all of these things have to be taken into consideration to see whether we're actually comparing apples and oranges when we're thinking about applying guidelines to older individuals. And finally, the outcomes of interest may be different, particularly in light of the fact that older individuals may not value the same things that younger individuals do. So a classic example, of course, is that many older individuals realize that mortality may be coming very soon, no matter what happens, and their priority is, and this may actually conflict with what we're doing in terms of trying to make them live longer. In 2006, we put together this paper on knowledge gaps in older adults. And unfortunately, I think many of the things that they said are still quite true. Although most guidelines in care of older adults should be individualized, there's substantial variability in the guidelines with respect to recommendations. And they came up with recommendations to address some of these, including in trying to get more older individuals in clinical trials, outcomes that are relevant to individuals, again, maybe function over mortality of care, and having better prognosis models that are involved with those, not just with younger individuals. And of course, when we think about goals of care, we have to think about some very specific things. I had the privilege of being part of a writing group years ago, looking at the care and particularly the discharge of patients who are admitted with failure. And we considered different groups, including the group that actually wasn't getting any better during their hospitalization. In fact, they may be worsening. And here's some important things that we have to think about. And you'll notice at the very bottom of the list there, we have to think about reevaluating comorbidities and alternative diagnoses, which are very common in older individuals. And in some cases, we have to seek additional expertise, particularly advanced heart failure, but also maybe palliative care, in order to really deal with these patients' goals of care, but also to help them to even feel better during their hospitalization if they're not doing better with our therapies. CardioSmart is a patient website from the American College of Cardiology that helps patients to be able to think through their disease processes and ask physicians good questions. And there's a section in there talking about planning for your care. It encourages patients to think about what's important. And you can see some of the questions that it advises patients to ask themselves to try to figure out what their goals of care are. And I would highly recommend that we think about asking our patients who are older and present with acute decompensated heart failure to think about some of these questions. That brings us to frailty. Again, from our top 10 list, frailty is the vital sign of old age, and functional status and revitalization are key priorities of care. And we have to think about them in order to maximize benefit for older individuals. Now, frailty has been defined in a number of different ways, but I think there's a consensus that it includes at least a loss of biologic reserves and a failure of homeostatic mechanisms that really complicate the ability of an older individual, or really any individual, to recover following a stressor event. And this involves a number of different things: sarcopenia or muscle wasting, malnutrition, dementia, depression, and disability. And it doesn't seem to matter too much what scale you use to measure frailty, because they all do a pretty good job at predicting mortality at 1 year. Some of them are a little bit better than others, but for the most part, all of them will show you which patients are going to be alive and which will not at 1 year. The psychological futility is a very important part of this. I think a lot of times we think about physical frailty, but really psychological frailty is key. And this can complicate informed consent and shared decision-making, as patients may not be able to understand what we're discussing. And of course, it complicates treatment, because polypharmacy is a whole lot more difficult to deal with if you have psychological futility, or frailty, excuse me. And if caregivers are having to deal with psychological aspects as well as physical aspects, and all of this can complicate adherence to complex medical therapies that we routinely involve in acute decompensated heart failure. But then there's also social frailty, and we have this issue of health literacy, and of course, the ever-present problem of treatment costs, and then visiting and testing burden on family members and caregivers, and of course, just the social environment. All of these things can actually play a role in causing an older individual to be frail and to complicate our treatments. This is an interesting study that was done as part of a parent study on physical rehabilitation interventions among patients hospitalized for acute heart failure. And they found some very interesting things in this study and in the parent study. And basically, the bottom line is that rehabilitation is very important. We can see that overall quality of life scores and also 6-minute walk tests get much better, and statistically so, when we apply a rehabilitation intervention. And that includes both patients who are frail beforehand, and then who are almost frail or pre-frail, and those that are actually frail. And so in summary, I like this central illustration looking at the different domains in approach to heart failure in older individuals. There's, of course, the medical domain, and we want to look at things like the etiology of heart failure and our pharmacologic treatments, polypharmacy that might actually complicate therapies, and of course, the comorbidities and whether we're going to treat them and create prescribing cascades, or how exactly we're going to deal with many comorbidities that patients have. And of course, it's important to think about malnutrition. But then there's the aspects of mind and emotion. We have to assess cognition. We have to screen for depression. And the physical function is going to complicate our titration of medicines. We have to think about fall risks in particular. And then increasingly, we need to realize that the social environment can impact our therapies. We have to ask about social supports and whether patients can afford their medications. And right in the middle of all of this, of course, is the crucial aspect of discussing goals of care. Patients need to be able to direct their care, but that requires us actually asking them what is important and how can we actually tailor our therapies in order to meet those goals. Well, thank you very much for your attention. I really appreciate the opportunity to participate in this great Congress.